Hi, this is Patrick Horn, president of GAP. Thank you to our sponsor AbbVie for their support of this FAQ video module.
Hi there, my name's Alison Krustapentus. I'm a nurse practitioner at Beth Deaconess Medical Center in Boston, Massachusetts. And I'm here today to talk about next steps when a patient still has active disease despite taking an advanced therapy. So first thing we want to do is make sure that the patient does have active disease. Oftentimes they're coming to us in office with development of symptoms saying, I think I might be flaring. We want to make sure that there is actually active disease and this isn't another course, such as irritable bowel syndrome, a functional bowel disorder, or infection. So one thing we want to do is get those objective measures, which would be a C-reactive protein blood test, a fecal calprotectin, if warranted, a cross-sectional imaging, or a colonoscopy or flexible sigmoidoscopy. If those results come back and do show that there is active disease, then we need to have a look and see where they started when they began this drug. If they started at a very inflamed level, then we want to see if they've had any improvement since starting that medication and see if they just need a little bit more time or perhaps some dose optimization. So what that would lead into is something like therapeutic drug monitoring, which I use specifically in my practice, and the anti-TNF agents to see if they're maintaining adequate drug level throughout their frequency dosing. So what I do is I get a trough level, which is a blood level right before they're about to take their next dose to see if they have enough drug on board or if they've developed antibodies. If a patient does not have enough drug on board, typically what I do is dose escalate. We get more bang for our buck increasing the frequency rather than the dosing, specifically in infliximab. So we will try that out to see if we can recapture remission in this patient. If it shows adequate drug level and the patient is still having active inflammation, then what we will do is often look to switch drug class. What that would look like is going to, if they're on an anti-TNF agent, going to an IL-23 or perhaps a JAK inhibitor, perhaps vedolizumab, but looking to change class because that's showing us that they're no longer responding to that given class. And to differentiate, primary non-response is when a patient has started a medication and has shown really no response to that given medication, despite giving them enough time to heal, versus secondary loss of response is the patient initially started to respond. We saw either full response or pretty significant response, and then they lost that response as we saw on biomarkers. So an important thing to remember is to check these biomarkers, these objective measures like fecal calprotectin, C-reactive protein, imaging, endoscopy, to really measure as we go through the course with this patient if we change frequency, change dosing, or if we change anything related to the drug itself. Thank you very much, and I hope you have a great day.